Hi, my name is Emily Ho, and I'm a neurologist at Swedish Medical Center and Harborview Medical Center at the University of Washington. I'm also an interpreting physician for Pacific Vascular. I want to thank the organizers of this conference for inviting me to give this talk, in which I will discuss carotid stenosis as well as carotid plaque morphology using a novel scoring system called Plaque RADS. This is my financial disclosure, and these are the abbreviations I'll be using in the next 30 minutes. So let's start with the case. This is a patient with recurrent strokes. He's an 82-year-old man with a history of recurrent strokes in the left hemisphere. His stroke risk factors include coronary artery disease, hypertension, and hyperlipidemia, and he presents to the emergency department with new onset right-sided weakness and aphasia. So let's review the patient's brain imaging over time. His story begins in 2015 when he developed right face and arm weakness, and as you can see on his brain MRI, there are areas of strokes in the left hemisphere as indicated by the arrows. A year later, in 2016, he had new onset cognitive change. He couldn't do math, and he presented to an outside hospital, and he was diagnosed with an acute left parietal stroke seen on brain MRI. Unfortunately, we don't have that imaging available, but he did come back to the Swedish Medical Center, and here is his head CT several weeks later, which showed the subacute left parietal stroke. In 2017, he developed right face and arm weakness, and here is his strokes on brain MRI as indicated by the arrow. And finally, a week later, we are at the present episode where he had aphasia and worsened right-sided weakness, and here his stroke is much more extensive and disabling. So let's review his vessel imaging. Here is his CTA head and neck axial view, the right ICA, the left ICA, and as indicated by the arrows, there's mild calcified plaque in the right carotid bifurcation, as well as 40% stenosis in the left ICA. And here's an oblique view of his carotid bifurcations, the right and the left sides, to give you an idea of his plaque burden. The patient was admitted to Swedish Medical Center, neurology was consulted, and a carotid duplex and TCD study were ordered. We're going to focus on this patient's left side of the study since it's clinically relevant. And here is his left common carotid artery. You can see that there is hyperechoic plaque on the axial view and the longitudinal view, and the calcified region is causing an acoustic shadow. Here is his left internal carotid artery, and you can see again there is a complex looking carotid plaque, and measurements showed that there's approximately 45% diameter reduction in the left ICA. Here's axial imaging and longitudinal imaging. The interpretation for this carotid duplex study is that the patient has less than 50% stenosis in the left ICA based on the velocity and the ratio. This is the patient's TCD emboli study. On the first study, no emboli were detected in the bilateral middle cerebral arteries. But on the second study, while there was no emboli detected in the right MCA, there was one embolic event detected in this 1 hour-long study in the left MCA. So this is a patient who's having recurrent left hemispheric strokes, and on vessel imaging, both CTA and carotid duplex showed mild left ICA stenosis. He has had an extensive stroke workup previously, including no evidence of atrial fibrillation despite multiple periods of cardiac monitoring and wearing an implantable loop recorder. And with consultation with hematology, there was no evidence of ongoing thrombophilia. The patient's TCD did indicate emboli from a proximal left source. This case was very puzzling to his providers, and he was discussed in a multidisciplinary cerebrovascular conference, and it was quite a heated discussion amongst neuroradiologists, neurologists, stroke team, neurosurgeons, and neurointerventional radiologists. And the consensus was that the patient's left ICA was implicated as the most likely cause of his ongoing strokes, despite the mild degree of stenosis. So now let's discuss carotid plaque. And I think we can all appreciate that carotid plaque can be complex and that there may be more to the story than just carotid stenosis alone. As a reminder, how do we assess carotid stenosis? Well, the most common criteria is using the NASCET protocol. And so this is calculated as a ratio of the linear luminal diameter at the narrowest segment of the diseased portion of the artery, as shown in measurement B, to the diameter of the artery beyond any post-stenotic dilatation, as indicated by A. There is a second way of assessing carotid stenosis through the European carotid surgery trial, but I won't go into details of that calculation, but it is shown here. So we know from multiple stroke trials that patients who have symptomatic strokes benefited from carotid intervention if they had a high-grade stenosis, specifically 70 to 99% stenosis. I now want to take you through how a carotid plaque develops. And we're going to use this figure, which looks like the life cycle of a carotid plaque. And it's taken from a pentachrome stain of tissue histology of a carotid artery. And so we'll start from panel A, which shows intimal thickening characterized by smooth muscle cells that accumulate within the intima. Over time, this becomes a xanthoma, as shown in panel B, where there's accumulation of foam cells within the intima. In panel C, there's pathological intimal thickening because there's an accumulation of lipid pools within the intima. And then finally, there is fibroatheroma development, and this is characterized by the development of a necrotic core and a fibrous cap. And eventually, this may heal and become a calcified lesion. So within this development of carotid plaque, there is a danger period in which the carotid plaque can become thrombogenic and puts the patient at risk for stroke. This happens when the plaque ruptures. So there's a defect in the fibrous cap that allows the core to become exposed to the blood, and then this becomes a source of thrombus that can then break off in the setting of ruptured plaque, causing a downstream stroke. I now want to turn to assessing carotid plaque morphology using carotid Plaque RADS. Here is the published manuscript describing the carotid Plaque RADS system. As you can see, it was published in 2024 in the Journal of American College of Cardiology Imaging. There's many authors, and if you scan through the list, there are a handful of authors who are local from the Pacific Northwest. This is a step-by-step flowchart to help you classify the Plaque RADS score for a carotid artery. And so the first step is to look for presence or absence of carotid plaque. If there isn't carotid plaque, the carotid artery has a score of 1. If, however, there is carotid plaque, then you look at the maximal wall thickness. If the wall thickness is less than 3 millimeters, the Plaque RADS score for a carotid artery is 2. If the maximal wall thickness is greater than 3 millimeters, then it's time to look at the morphology of the plaque. And depending on the absence or presence of ulceration, as well as the thickness of the fibrous cap, this would place the carotid plaque in a score of 3. Finally, the highest score on the Plaque RADS scale is 4, and for those plaque that have morphology with high risk, including intraplaque hemorrhage, ruptured plaque, or intraluminal thrombus, these features would place the plaque as having a Plaque RADS score of 4. We're now going to discuss each individual Plaque RADS score, and to make it more fun, I'm going to ask SpongeBob and his friends to go through each individual Plaque RADS score with me. So let's take a journey to the seafloor. So a Plaque RADS score of 1 is a normal vessel wall. And in SpongeBob's world, this means that the ocean floor is very smooth, it's very peaceful, and there's no trouble or mayhem. And here's an example of an ultrasound of a normal carotid bifurcation with a normal vessel wall. What does a Plaque RADS score of 2 mean? Well, it means that there's wall thickening. And in SpongeBob's world, there's something on the ocean floor. For the carotid vessel, it means that the wall thickening is less than 3 millimeters. And how do we determine maximal wall thickness, or MWT? Well, it's a linear measurement of the greatest thickness of the vessel wall on axial imaging. So it's perpendicular to the vessel's long axis. And the wall thickening should include the arterial vessel wall, as well as both calcified and non-calcified components of the plaque. So here's an example of a carotid plaque with a score of 2, and as you can see, the maximal wall thickness is 2.4 millimeters, and looking at the axial and longitudinal views, there is both non-calcified and calcified elements in the plaque, with the calcified elements causing an acoustic shadow. Moving on to the Plaque RADS score of 3, this is where things get a little bit more complicated. The ocean floor has a lot of lumps and bumps, and for the carotid bifurcation, the maximal wall thickness is 3 millimeters or more. Plaque RADS score of 3A means that there is plaque with a thick fibrous cap. And here we have an example on ultrasound. This is a large plaque in the carotid bifurcation with uniform isoechoic plaque where one can actually appreciate there's a fibrous cap on both longitudinal and transverse views. And you can appreciate the on flow imaging what the carotid plaque looks like. And this is what it looks like on histology. So Plaque RADS score of 3B means that the fibrous cap is really hard to see on ultrasound. And here's an example. This is a plaque that has hyperechoic regions as well as hypoechoic regions. And the authors use a term of JBA, juxtaluminal black areas, because on beam imaging, it's really hard to visualize the plaque. It's much easier to see the silhouette of the plaque using color flow. What you can appreciate is that the JBA is really dark because the fibrous cap is so thin, it can't be visualized. And so the authors actually use an outline to show you both the anterior and posterior components of this patient's plaque. And the final subcategory in Plaque RADS score of 3 is 3C, ulcerated plaque. Histologically, ulceration means that there's an intimal defect that's 1 millimeter or more. And consequently, there's exposure of the plaques in the carotid core to the vascular lumen. And on carotid studies or other vessel studies, most likely the atheromatous material has already left the area and there's a healed plaque from previous rupture. And so here's an example on histology of an ulcerated plaque. And here's an example on ultrasound and CT. So let's focus on the top panel. The area of ulceration is shown by the asterisk, and this is shown on both longitudinal flow imaging, conventional B-mode imaging, axial imaging, and coronal views. And I think that we've all appreciated areas of ulcerated plaque if you look enough times. Here's an example on CT. This is a CTA of a patient, and as you can see, the area of ulceration is this outpouching of contrast in the vessel wall. The highest Plaque RADS score is a score of 4, and this is high-risk plaque. So in SpongeBob's world, this is something very dangerous that's coming out of the seafloor. In terms of the carotid bifurcation, it means that there's presence of intraplaque hemorrhage, ruptured fibrous cap, or even intraluminal thrombus. And this is independent of plaque thickness. So I won't spend too much time on Plaque RADS score 4A, intraplaque hemorrhage, because it's really hard to see this with ultrasound. MRI is the most sensitive image modality for detecting intraplaque hemorrhage. Plaque RADS score of 4B is a ruptured fibrin plaque, as shown here on histology. And here's an example of a ruptured fibrin plaque on ultrasound. So what we see is that there is a free flap visible in the lumen that's hyperechoic. The lipid-rich region is not visible, and presumably it's been discharged. However, on color flow, what you can appreciate is that the flow is perturbed, and some of it's actually reversing. This blue area just above the flap is the reversed flow, suggesting that the flap is free from the wall, and this would be a high-risk plaque. And I wonder if we had cine loops of this carotid study, we might actually be able to appreciate movement of the free fibrin flap on the ultrasound. So Plaque RADS 4C is intraluminal thrombus, and here's an example, the top panel being an ultrasound study. And as you can appreciate, the plaque looks very complex with both hyper and hypoechoic regions. And the open arrow where my laser pointer is actually depicts a JBA, or juxtaluminal black area. And this is possible thrombus. This patient also has a high-grade stenosis with NASA criteria of 72% stenosis. So this is a very ugly-looking plaque. On CT scan, what does intraluminal thrombus look like? Well, there's a term that's used as donut sign, as shown here, where the thrombus is sitting within the vessel lumen. We also use the term worm in a hole. And here is the axial image, sagittal image, and coronal image of an intraluminal thrombus. Why do we care about intraluminal thrombus? Well, it's very high risk for stroke. It's associated with neurological symptoms in up to 92% of cases in this report from 2015. And it predicts that the stroke is coming from a carotid source. Intraluminal thrombus is also the strongest predictor of carotid source for stroke if one excludes non-carotid plaque causing strokes, a carotid occlusion, or near occlusions. And in instances of intraluminal thrombus, the odds ratio for stroke is 103, and it's statistically significant. Here's a patient that I encountered when I was reading his carotid study. He's 36 years old. He has a medical history significant for a hypercoagulability disorder, resulting in multiple episodes of pulmonary emboli. And despite medical advice, he stopped taking anticoagulation for the past 6 months. And he presented to an outside emergency department with new onset left-sided weakness concerning for a right MCA stroke. And his NA stroke scale was quite high, being 17. Here is his CTA, and what you can appreciate is that there is a worm in a hole or a donut sign in his right common carotid artery. And you can see the presence of the thrombus on both the coronal and sagittal imaging as indicated by the arrows. The patient underwent emergent thrombectomy for this clot. And now we'll look at his carotid duplex that was done after his thrombectomy. So this is follow-up imaging. And you can see that there is a hypoechoic plaque present in the right internal carotid artery. It's much better appreciated on power Doppler. Here's a cine loop of the patient's right ICA on longitudinal view, and I turned up the brightness of the cine loop to help you better appreciate the presence of the thrombus within the lumen of the vessel. And here are the axial cine loops. Again, you can appreciate the hypoechoic plaque with some speckled calcifications. So after thrombectomy, the patient still had acute thrombus visualized in the distal right common carotid artery extending into the carotid bifurcation. And by velocity criteria and the ratio, he falls into the category of 50 to 69% stenosis in the right ICA. I also want to note that this was based on the previous carotid criteria. Here's a summary of the Plaque RADS scoring system, starting from the left-hand corner, Plaque RADS score of 1, which is normal, and then going to the right, Plaque RADS score of 2 with a maximal wall thickness of less than 3 millimeters. Plaque RADS score 3 is a maximal wall thickness of greater than 3 millimeters, with 3A showing thick fibrous cap, 3B showing thin fibrous cap, and 3C showing an ulcerated plaque. And finally, the Plaque RADS score of 4 shows the high-risk plaque features of intraplaque hemorrhage, fibrous cap rupture, or intraluminal thrombus. And I want to point out that the higher the Plaque RADS score, the more vulnerable the plaque, and clinically for the patient, the higher the risk of stroke. Finally, there are additional ancillary features as shown here on the right-hand column, including calcifications, signs of neovascularization, plaque inflammation, remodeling, or even progression of stenosis, as well as additional modifiers, including a limited diagnostic study, presence of a carotid stent, or presence of a previous CEA. So I now want to discuss some nuances with looking at carotid plaque using ultrasound and the Plaque RADS scoring system. First, hypoechoic plaque are large lipid-rich necrotic cores, which gives you a Plaque RADS score of 3A or 3B, and I often use the term soft plaque. Lipid-rich necrotic core with a thin fibrous caps are seen as juxtaluminal black areas, or JBA. So this gives you a Plaque RADS score of 3B. However, ultrasound cannot distinguish large lipid-rich necrotic core from intraplaque hemorrhage, which is a Plaque RADS score of 4A. In addition, JBA may also represent plaque rupture, a score of 4B, or even intraluminal thrombus in some circumstances, which is a score of 4C. So looking at the summary of the Plaque RADS scoring system using ultrasound alone, there is a gray area where it's hard to distinguish whether a hypoechoic plaque falls in the score of 3B, 4A, 4B, or 4C. So for the clinicians, the authors had a helpful guidance that for those patients who have a hypoechoic plaque of greater than 3 millimeters without a visible fibrous cap, or if there's presence of a juxtaluminal black area, a JBA, one should consider using MRI to further assess the patient's plaque morphology, specifically to look for presence of intraplaque hemorrhage or even plaque rupture. So going back to our patient who had the recurrent strokes, let's re-examine his carotid duplex study. As you will recall, he had less than 50% stenosis in the left ICA by NASCET criteria. With the knowledge of the Plaque RADS scoring system, let's reevaluate his carotid plaque. On axial imaging, as you will recall, the plaque looks a little complex. There's both hyper and hypoechoic regions. And looking at the maximal wall thickness, it's 3.8 millimeters. And I think I can appreciate on these axial images the presence of a fibrous cap. However, on longitudinal imaging, it's a little less clear, and where the arrow indicates, it makes me wonder if there's a JBA or juxtaluminal black area. If we were to apply the Plaque RADS score to this study, we know that the patient has less than 50% stenosis in the left ICA, and if we were to describe the plaque, it's mixed echogenicity. There's hyper and hypoechoic regions in the plaque. The maximal wall thickness is 3.8 millimeters. And the Plaque RADS score, well, I think it's a little bit hard to delineate. It could be ranging from 3B, 4A, or 4B. There wasn't a comment that there was a mobile element, so I'm going to take away the presence of an intraluminal thrombus for this patient. So for this patient, given the presence of a JBA on his carotid ultrasound, his Plaque RADS score could be 3B, but we cannot rule out the presence of high-risk plaque with a score of 4A or 4B. And knowing what I know now, and having learned through the Plaque RADS scoring system the benefit of MRI, I probably would have sent this patient for an MRI study of his carotid bifurcation to further risk stratify his carotid artery. In the end, after discussion in the multidisciplinary cerebrovascular conference, the consensus was that we should send this patient for our left carotid stent, given he continued to have left hemispheric strokes that were recurring. In summary, Plaque RADS is a 4-point plaque vulnerability scoring system, and it allows us to report carotid plaque composition and morphology. And it gives us an opportunity to evaluate carotid artery disease beyond carotid stenosis in order to help predict a patient's risk for future stroke events. And I think it's very helpful to create, because it's a common language between sonographers, CT and MRI specialists, treating clinicians, and research scientists. The advantages of the Plaque RADS system is that it can be applied across multiple imaging modalities, and it incorporates current research findings and has the potential to be applied in future clinical trials to study carotid atherosclerosis. The limitation currently is that it has yet to be validated in larger cohorts. So here's a suggested method for incorporating the Plaque RADS score into your carotid study. In addition to the side of the carotid, the degree of stenosis by NASCET criteria, ancillary features such as progression of plaque, or modifiers such as a technically limited study or presence of CEA or stent, I think it would be helpful to think about the patient's Plaque RADS score and put it in your study, and also measure the maximal wall thickness and include it into your study. So this is my last slide. Thank you so much for your attention. I'd really love to hear what you think of the carotid Plaque RADS scoring system. I know within our group at Swedish Medical Center, it will generate a lot of discussion. So please feel free to reach out to me at my email as listed here. I hope you all have a great day, and I wish you a great conference. Thank you.